I think about a third of people will have some cardiovascular event while they're hospitalized. Some people have said that atrial fibrillation alone may occur in as much as 40% or so of patients with sepsis.
That is a stat, actually, I did not know.
Yeah.
That is a crazy stat, if you think about it. For up to 40%.
Yeah.
This is the Sepsis Spectrum, a podcast about antimicrobial resistance, sepsis, and how to expect the unexpected in your practice.
Sepsis Alliance gratefully acknowledges the monetary support provided by Vantive for this podcast series.
My name is Mary Millard, and I live in the Baton Rouge area of Louisiana. And I'm a retired nurse, being forced to retire, kind of what happened to me. I went into the hospital in 2014, and they found a large aneurysm on my aorta at the base of my heart, and it had partially collapsed my valve. 3 days later, a day before the surgery, I went to a cardiac arrest, full arrest. They could not bring me back with the paddles 3 times. I had a 6-minute and 45-second code. And after that, they decided to do ECMO. It's a machine, and it circulates and oxygenates your blood for you. I was on ECMO for about a week. My own heart started coming back after they cleared it. I had been weakened quite a bit. And they did the surgery. They told me, you're going to go home in about 10 days and everything will be fine. Later, I was put into step down, and my husband said he came into the room and he found me with my head hanging down, burning up, and I was talking incoherently. And this is where it went a little bit wrong. The nurse did not come in and assess me. They sent me to neurology to get a workup, and I was in neurology for 7 hours. And there's a note at the end of the neurologist assessment that said possibly sepsis. It was a very hard journey. I've also had to get a internal pacemaker because the oxidative stress from that sepsis hardened the heart, and it has a hard time beating. I'm told I can never get a transplant because I have all kinds of artificial plumbing there. And I suffer from PTSD. Every time I go into a hospital, I smell those gowns, I smell the tubing, and I just shut down. I just want to let people know that hospital-acquired infections kills a lot of people, and 1 in 25 is a lot of people, and we need prevention to help prevent sepsis.
Hi, everyone, and welcome to the Sepsis Spectrum. I'm Nicole Kupchik, critical care nurse, clinical nurse specialist, and your guide through the wide, unpredictable world of sepsis, or as we like to call this season, sepsis and multi-organ dysfunction syndrome. On today's episode, we're going to examine the relationship between sepsis and cardiovascular injury. Specifically, how infection can overwhelm the very system that keeps our organs alive. We just heard from Mary Millard, a sepsis survivor who went in for heart surgery and, as one setback led to another, experienced firsthand how sepsis can become the first domino in a devastating, life-altering chain of events. Mary's testimonial is an all too familiar one. I think it really hammers home that sepsis doesn't just lower the blood pressure or come and go. It leaves its mark. It disrupts the entire network of vessels, valves, and electrical rhythms that keeps the body in motion. And yes, the heart can survive the arrest, but what often remains is a chronic struggle with weakened organs and the long shadow of invasive care. The heart is built to endure, but in sepsis, even that resilience is tested. Blood vessels lose tone, the heart weakens, and inflammation sets the stage for long-term damage. Joining me today is Dr. Mitchell Elkind, Chief Science Officer for Brain Health and Stroke at the American Heart Association. Dr. Elkind is a vascular and stroke neurologist whose research explores how infection and inflammation disrupt the cardiovascular system. From the acute risk of heart attack, stroke, and atrial fibrillation to the lasting vascular changes that raise risk long after recovery. Together, we look at how sepsis leaves its mark on the heart, why survivors face persistent cardiovascular risk, and what true recovery means once the crisis has passed. We'll be right back with Dr. Mitchell Elkind. I am so excited to welcome to the show Dr. Mitchell Elkind. So, welcome, Dr. Elkind.
Thank you so much, Nicole. Delighted to be here.
Yeah, so you're working on some pretty amazing things at the American Heart Association. Can you kind of fill us in on what's going on?
Of course. So I'm the Chief Science Officer for Brain Health and Stroke at the American Heart Association. And as you may know, the American Heart Association has just celebrated 100 years. We just had our 100th birthday. And we're moving on to think about what we're going to do in the next century. And we're focusing, among many other things, on the brain. So certainly we've done stroke for a long time, but now we're looking into other aspects of brain health as well, like cognitive aging and dementia and other neurological conditions too. And we're also super interested in the connection between the rest of the body and the brain. And I think sepsis is a perfect example of how that happens.
That's really exciting, actually, to hear where kind of research is going to be driven next. So, all right, so we're talking about a very complex subject today. We're talking about sepsis, and we both know that sepsis has profound effects on the body, both in the acute phase, but also in the recovery phase. And so, one of the things I wanted to chat about today, so let's say we've got a patient who survived sepsis, septic shock, delirium. Let's just pile it all on. And now they're getting discharged. They're going home or maybe to a rehab facility. What types of things do patients now have to deal with once they're in the recovery phase of sepsis from a neurologic standpoint?
Well, from a neurologic and a cardiovascular standpoint, we think about the effects of sepsis on a person as happening, at least I think of it as happening in kind of three different time periods or epochs, if you will. There's what happens acutely to the heart and the brain when somebody's in the hospital, and particularly in the, throes of being in the intensive care unit, the most acute phase. There's things that can happen to the heart and the brain in that setting. And then over the kind of short term, maybe weeks to perhaps even months after that acute event, there's some long-lasting effects of the sepsis that can lead to cardiovascular and neurological problems. And then there's even a long-term phase going out months to years, many years even, suggesting that sepsis can have long-term consequences. So I think what we want to begin to think about is how we prepare to manage the person over the long term after an episode of sepsis. For example, if there's an increased risk of cardiovascular events like heart attacks or strokes, what can we do for people to try to prevent those from happening?
Well, and I think we've seen so many times, even while patients are hospitalized from a cardiovascular standpoint, we'll see cardiac dysfunction. We even see a traditionally non cardiac patient go into atrial fibrillation. So, long term, does that same patient have those risks?
They do. They do. A lot of the epidemiological literature suggests that there's a risk of heart attacks and strokes and heart failure that continues for months to years after the acute event. And as you said, that can happen even in people who don't have a previous history of heart disease. I think many of us have this idea that when somebody who has a known history of heart failure, or they have cerebrovascular disease, or maybe dementia, that they're at elevated risk of having complications when they have sepsis. And that's certainly true. But you don't have to have those predisposing conditions or pre-existing conditions in order to suffer the consequences, the long-term consequences of sepsis. And in fact, in some of the epidemiological work that we've done at Columbia University, for example, we found that some of these effects of sepsis as a risk factor for long-term stroke risk actually suggests that people who are younger tend to have a higher risk than people who are older. It may be a reflection of the fact that older people have lots of other reasons to have these cardiovascular events. So the specific impact of having a septic event and being hospitalized with sepsis are less. And so the impact of the sepsis itself tends to have a longer effect. I also think people don't realize that, we all have this idea that when you have an acute episode of sepsis, the inflammatory measures, the cytokines, go up acutely, and certainly they do, and they can go up to, extremely high levels. And then we expect that as a person recovers, those go back down, and they do, but they don't necessarily go back down to normal. They actually remain elevated for a long period after sepsis, and they may even remain elevated for months to years afterwards. So a severe infection can lead to long-term inflammatory and other complications.
So when we get down to the root of like what is causing all these long-term effects, so we know inflammation plays a huge part. What else lends to the long-term effects that we're seeing with?
Yeah, so there's probably a number of different things that happen, and inflammation we know is tightly linked to the clotting system, the coagulation system of the body, right? So we talk now about this phenomenon of thromboinflammation, recognizing the links between inflammation and blood clotting. And this became very much more recognized during the COVID pandemic when we saw in many, many patients who were severely ill acutely with COVID, that they could develop this thromboinflammatory phenomenon. They would develop blood clots. I mean, certainly I took care of even young people who had no good reason to have bad clotting disorders or strokes. They would come in sometimes with mild cases of COVID, and yet they would have large blood clots in the carotid artery or the arteries in the brain or even in the heart. And so the same phenomenon can occur in people after sepsis of other causes too. It's not limited to only COVID. We just saw a lot of it, which is why we became so aware of it at that time. And so blood clotting, coagulopathy, primarily thrombosis, but even in some cases, hemorrhage can be an important consequence of that kind of inflammation. But there are other mechanisms too. Inflammation can contribute to atherosclerosis, atheroma formation in the blood vessels, whether it's the coronary arteries, the carotid arteries, or the aorta and other blood vessels. Um, the inflammatory process plays an important role in the development of atherosclerosis. In the old days, we used to think of hardening of the arteries as being primarily a lipid-driven process, that you would deposit cholesterol in the blood vessels and they would thicken over time. But we understand now that a lot of that process is really driven by inflammation, and it may be in part or largely due to a reaction against oxidized lipid particles, but it can also be a reaction against other um, stimulants, including potentially infectious agents. And so that can lead to thickening of the arteries and, again, risk of stroke and heart attacks over time. And animal models have shown this as well. So you can induce atheroma in the aorta of animals by exposing them to certain severe infectious agents. And so there's good evidence from the epidemiology side as well as the kind of mechanistic experimental side that this sort of phenomenon occurs. We don't quite know exactly what to do about it yet, but we do think that happens.
And do you feel that perhaps like statins can play a role, or maybe even like metformin or the GLP-1 drugs? Is there a role for any of these medications?
Well, we don't know the answer to that yet. So currently, the way that we think about long-term prevention of cardiovascular events, right, is to do a calculation of somebody's risk. Primary care doctors, for example, are supposed to use a risk prediction tool or algorithm. The American Heart Association has a new one now called the Prevent Risk Calculator that accounts for your blood pressure, your blood sugar, your history of, diabetes and family history and so forth. And you can find these calculators online, and then you can estimate somebody's long-term risk. And if their risk is above a certain threshold, then you would begin them on statin therapy, not just because they have an increase in cholesterol, for example, but because their overall risk is high enough. And one really important question in my mind is whether a history of sepsis should be considered a risk factor like, a history of diabetes or a history of hypertension. We don't have the answer to that question yet, though. And so, the risk calculators don't yet include a history of sepsis, for example. But the observational data would suggest that, in fact, people who do have a history of sepsis probably are at higher risk. And I think we're just at the point now where the research is starting to look into that question. Do we include history of sepsis as part of our risk estimation for the future long-term risk in people?
Yeah, because I mean, so many of these patients get discharged, and it's like discharged to who, right? Their primary care provider, who, how do you even, how do you identify who that high risk patient is, right? So, do you know of any programs where they're measuring inflammatory markers or things like that once a patient gets discharged after having sepsis?
Well, we don't have any programs that I'm aware of that do that yet because the research kind of hasn't risen to that level. We do know from certain clinical trials, though, in patients with cardiovascular disease, that elevated levels of certain inflammatory markers like C-reactive protein and IL-6 can be beneficial in predicting risk, especially in people who don't have other risk factors for cardiovascular events. And we know that certain agents, certain drugs that target the immune system can actually help to prevent cardiovascular events. So, for example, canakinumab, which is a monoclonal antibody directed against the IL-1 receptor, can have an effect on reducing the risk of future cardiovascular events in people who've already had a first MI or heart attack, for example. And similarly, colchicine, another anti-inflammatory agent, seems to have some benefit in reducing future risk. So whether we should be giving, those drugs or statins to people with an initial septic event, even if they don't have high cholesterol, let's say, is an open question and one that I think needs clinical trials to determine the answer. One issue there is that even in people who have sepsis, although they may be at increased risk in the future, um, the absolute risks are still low. So in some of our work, for example, we found that after sepsis, the risk of having a stroke was about 0.5%, right? So 1 in 200 people would go on to have a stroke within several months of the septic event. So the risk, in absolute terms is low, even though they were higher for somebody who had sepsis than for somebody who didn't. So what that means, right, is that in order to have a clinical trial that demonstrates a benefit of a preventive treatment, you need to have a huge sample size to demonstrate it. So that is a limitation. And, I think what that also tells us is that we need better ways of predicting which patients with sepsis will go on to develop strokes or heart attacks or other events. And, that's work that's ongoing.
Yeah, and I mean, what a heterogeneous population, right? Which would be really challenging. All right, so we're gonna go to break, and when we come back, we're gonna pick up where we left off and kind of talk about where the research is going and what we can do in the meantime. Are you a healthcare professional who wants to stay ahead of the curve? Visit sepsispodcast.org to learn more about how you can receive free CME and nursing CE credits by listening to or watching the Sepsis Spectrum. It's our way of supporting you and together better understanding the ever-evolving world of sepsis care. And now, back to the show. Welcome back from our break. We're going to kind of back things up just a bit and talk about the acute phase of sepsis and some of the cardiovascular events that we're seeing. Now, Dr. Elkind, I've worked at the bedside clinically for over 3 decades, and it is always surprising to me when I see these septic patients go into AFib and AFib with RVR, and I'm like, why is this happening? Because they really have no cardiac history. Can we talk a little bit about like why we might be seeing AFib in this patient population or even like cardiac dysfunction in general in the acute phase?
Yeah, sure. Well, first of all, as you know, cardiovascular events, including atrial fibrillation, but others as well, are quite common in patients with sepsis. I think about a third of people will have some cardiovascular event while they're hospitalized. And some people have said that atrial fibrillation alone may occur in as much as 40% or so of patients with sepsis.
That is a stat, actually, I did not know. That is
Yeah,
a crazy
yeah,
stat if you think about it, for up to 40%.
yeah. And again, not even people who necessarily have a cardiac history, as you said. I mean, it may be that it's, sepsis is a kind of stress test, if you will. I think some of the, and maybe we'll come back to this, but some of the ways that we think about sepsis and cardiovascular disease, I think are similar to the way that we think about pregnancy, frankly, in cardiovascular events. A lot of people talk about pregnancy being a kind of stress test of the body, and it can bring on hypertension, can bring on diabetes, and people can have strokes and cardiovascular events in the setting of or shortly after pregnancy. And I think, we can think about sepsis almost in the same way. It's a stress to the body, of course. And sepsis in particular puts great demands on the heart, right? So, there's changes in volume status. When people are febrile, the heart is pumping harder and faster. And there are changes in fluid status, and there's third spacing of fluid, and there's, a decrease in volume within the bloodstream itself. And so all of these fluid changes and cardiac changes and autonomic changes as a result put greater stress on the heart. And so that's probably why we see an increased risk of atrial fibrillation, why we see an increased risk of heart failure as well, because with the increased demand, especially in people who are already compromised in some way with past history of ischemic disease or something of that sort, then they're more likely to suffer those consequences. Um, and then on top of it, I think some of these inflammatory effects can contribute. And I think of the very high risk of encephalopathy that we see in people with sepsis. As a neurologist, that's usually why I get called in to see somebody in the ICU who's septic, is because either they're having a stroke or they're having something that makes the team worried about a stroke. And, it may be this more generalized delirium or encephalopathy. And we know that inflammatory molecules, cytokines, and others can contribute to this encephalopathy. We don't 100% understand how that happens, but just like the kidneys don't work right in sepsis, the brain doesn't work right in sepsis. And so it's really a combination of multiple effects, again, inflammation, cardiac demands, and some of it could be secondary to medications that are used as well, right? So as we're treating people with antibiotics and autonomic agents and pathomimetics and so forth, those can have their own impacts on cardiac function that may lead to heart failure or atrial fibrillation. So teasing out the exact single cause is going to be challenging. These are patients who are sick and have a lot going on.
Yeah, well, and for a while there, the buzz was it was myocardial depressant factor. Is that a thing? anymore? Or do we talk about those types of markers?
Yes, I think that there can certainly be a cardiomyopathy that occurs in the setting of sepsis. We again certainly saw a lot of that during COVID as well. And yeah, and so the autonomic effects can be quite profound in some patients. And there may be some specificity depending on the agent or organism that's causing the septic syndrome. There is probably an impact of the severity of the infection as well, and certainly the premorbid state of an individual, what their own cardiac function was, and who's kind of on the threshold, and it just takes a little bit to push them over the edge.
And it's that whole sepsis brain connection as well. I mean, you always hear like as we jokingly say in the hospital, we make fun of the emergency department, just in fun, right? But you're getting an 82-year-old who's got a urinary tract infection who's pleasantly confused, and then that poor patient gets labeled dementia when they didn't have dementia, right? They've got an encephalopathy from their sepsis.
Yeah, thank you for posing it that way too, because I think a lot of people don't think of encephalopathy versus long-term consequences like dementia, and certainly people can have the acute effect without necessarily going on to have long-term problems, and it's important to keep that in mind. I think it does inform how we prognosticate among patients. I can't tell you how many times somebody will say, "Oh, well, they're just demented. Like, don't worry or don't bother with them." But often we don't know, and people make assumptions about somebody's neurological status based on how they are acutely rather than what they were before or may become afterwards. But that said, it's also important to keep in mind that sepsis, just like almost any acute insult, can lead to or be a trigger for um, the beginning of a dementia. It's quite common, for example, that we'll see even after orthopedic surgery when somebody wakes up but they're not quite right, and it may be the first time that family members appreciate cognitive impairment. So, people may have been declining slowly, but nobody really noticed it. Then they have an episode like sepsis, and they're never quite the same after that. And so I think, again, some of those things that happen acutely persist long term, certainly weeks, maybe months, or even years after the event. And, uh, again, that's why it's helpful to use the septic episode, or hospitalization as an opportunity to reevaluate both neurologic and cardiovascular function and see whether somebody may need to be on statins or, antithrombotic therapies or blood pressure medications, be assessed if necessary for a neurodegenerative condition that nowadays we do have treatments for. We have drugs for Alzheimer's disease and so forth. So when people survive the acute event, we don't want to forget about the fact that they still have a lifetime ahead of them and that we can try to address those problems as well. Again, it's not unlike the situation with pregnancy, where there's a real movement now to think about what might happen acutely during pregnancy as an opportunity to then take care of the mother long term after that acute event as well.
Now, let me ask you this. So many times when patients do get discharged home, they're left in the care of their primary care provider, which I'm sure, and I know there's new codes that they can spend more time with the patient for reimbursement and things like that. But I mean, truly, what advice would you have to a discharging physician or nurse practitioner as far as longer term referrals? Like, what types of specialists would you say, I'd really think about this when this complex patient is getting discharged?
Well, I think that the uh, the the focus should be on these kinds of long-term consequences that might arise, and I think that a good primary care doctor would certainly be, person number one to continue to follow somebody after an event like this, and someone who's attuned to the possibility of these cardiovascular and neurologic long-term effects. Now, that's not to say every patient after sepsis needs to see a cardiologist and a neurologist, but I think if somebody has had cardiovascular complications, of course, during the septic hospitalization, or has had certainly neurologic complications, that might be somebody who should then be followed by the appropriate specialists. Again, because the sepsis and the things that happen in the hospital may just be the first indication of what could be a longer term problem. Um, again, thinking about these kinds of long term effects after sepsis or even milder infections. So honestly, some of our uh, observational studies and research have shown that it doesn't even have to be sepsis to put somebody at increased risk of future strokes and heart attacks. Uh, Even upper respiratory infections that are milder, like viral upper respiratory infections or episodes of pneumonia, can lead to later heart failure and stroke
Really?
risk. Yeah.
Huh. That's fascinating.
Yeah, and it's probably again a question of severity. So certainly sepsis is it's kind of the peak severity of an infectious event and brings with it a lot of the thromboinflammation and cardiovascular effects. But milder infections may do the same thing in some cases as well. It's a question of how severe the infection is, as well as what the host response is. Different people are going to react to an infection in different ways. And so, certain patients are more likely to develop these complications than others. We have found, for example, that people with a history of certain kinds of cancer, or certainly people who have a history of uh, DVT or pulmonary embolism, seem to be at increased risk as well. So, it's not only the infection; it's the individual suffering the infection that drives these kinds of phenomena. But we know, for example, that vaccination is important for prevention of not only the infection, like flu vaccination, for example, is recommended for patients who have a history of cardiovascular disease to prevent future cardiovascular events. Because if you have heart disease and you have the flu, you're more likely to have a heart attack. And one could imagine a similar approach in people who've had sepsis. So you've had sepsis, boy, you should really be careful about not getting flu, not getting, streptococcal pneumonia, and other things that we can prevent with COVID, certainly, other things that we can prevent with vaccination to avoid those secondary cardiovascular complications. So I think, vaccination is an important part, primary care doctor, where necessary, neurologists, cardiologists, where people have those kinds of problems, and thinking again about traditional vascular prevention. If somebody's at high enough risk, so statins, antiplatelet agents, or antihypertensives, or medications for metabolic disease like the GLP-1s, whatever is appropriate in that individual's case.
Well, and there's so much interesting research that is blossoming about GLP-1 drugs right now, and it's going to be, I think, exciting to see if there is a connection in these patients who are in a chronic state of inflammation and possibly going on a GLP-1 drug for that. So I recently was diagnosed with cancer, and luckily, surgery took care of it. But my physician actually recommended, my surgeon, oncology surgeon, recommended I go on a GLP-1 just to decrease the recurrence risk by decreasing inflammation.
Yeah, well, I'm glad to hear you're doing well. And that's interesting about the GLP-1 in that setting. I wasn't aware, but in neurology, certainly, where we're seeing all kinds of potential uses. We need a lot more data, certainly, but in addictive behaviors, including substance abuse and even gambling and alcohol abuse and so forth, there seems to be a benefit.
Yeah, clinicaltrials.gov. You can see all the studies that are ongoing. So, all right. Well, I want to thank you for being here today. And if you could give our listeners 1 to 2 takeaway points about our discussion and just things that you're thinking of and you're seeing in your position with the American Heart Association, what are a couple takeaways that you would send our listeners off with?
So I think of sepsis as having several different effects, and one of them is certainly acutely. And thanks to the Sepsis Alliance for addressing those acute complications. And I know how much great work is being done by the organization and making sure sepsis care is as good as it can be everywhere. Um, I think that it's interesting to think about sepsis as another cardiovascular risk factor, and stroke risk factor specifically is how I think about it. And I think we're just beginning to understand that. We're just beginning to get the data in showing the implications of having a severe infection, particularly sepsis, on one's long-term health, and that the impact doesn't go away immediately, that suffering an event like sepsis carries with it months, if not years, of long-term effects. And so we need to figure out what to do about that. And that's where I think exciting research is going to come in the future, is how we adjust the vascular prevention medications, how we handle vaccination in that setting, and how we use anti-inflammatory medications to help reduce the risk associated with sepsis long-term as well.
Well, I just want to thank you for being here today. You definitely have enlightened me on quite a few things here in our discussion. And I want to thank you for all the work that you're doing with the American Heart Association. It's very impressive to read your CV and just know all the science and moving science forward and all the work that you've been doing in that field. So just thank you so much for everything you've been doing.
Of course, my pleasure. Thank you again for having me and the American Heart Association here today.
Well, thanks for joining us on this episode. Just to reflect on what Dr. Elkind and I talked about, I think it just makes you realize how absolutely complex sepsis is and can be, and how challenging it is for so many primary care providers to manage these patients once they get discharged from the hospital. But, especially just drilling down, just knowing that inflammation can really wreak havoc on someone's body, especially someone who, as a baseline, is at risk for cardiovascular disease. It's very thought-provoking. So anyway, well, I want to thank you for joining me on today's episode of the Sepsis Spectrum. If you have a story you want me to read on the air, visit www.human-content.com/sepsis. And if you're enjoying the Sepsis Spectrum, we want to hear about it. Please leave a review wherever you're enjoying this podcast. It helps a ton. You can also reach me and our awesome team at info@sepsis.org or visit sepsispodcast.org to share any stories of your own, questions, concerns, or episode ideas. To learn more about Sepsis Alliance, visit sepsis.org. The Sepsis Spectrum is brought to you by Sepsis Alliance. I'm your host, Nicole Kupchik. Our executive producers are Allison Strickland, Hannah Sass, Claudia Orth, and Alex Colvin. Our producers are Aaron Corney, Rob Goldman, Shanti Brook, and me, Nicole Kupchik. Our post-production producer is Sundas Hasoon Noli. Our editor and engineer is Jason Portizo, and our music is by Omer Benzvi. To learn about Sepsis Alliance's podcast, legal disclaimer, and compliance policies, you can visit sepsispodcast.org/disclaimers. The Sepsis Spectrum is a Human Content and Sepsis Alliance production. Thanks for watching. I hope you're enjoying the Sepsis Spectrum. Leave a comment below and let me know. If you want to binge some more episodes, just click that playlist right over there. And if you're feeling super generous today, give this video a like, subscribe if you haven't, hit the bell, all the things. And of course, you can also listen on the go wherever you get your podcasts. Bye.